Perfect. Looking good over here. Great. Yep. So.
Good. And the recording's good to go.
Beautiful. Thanks, mate.
I can't guarantee that I'll still be there by the time that you get up.
I think mine's all up, so I just
Yours
have
is
to
all
go.
done, it's all sorted. So I paid someone $500 for so that you can fix some. This is mine.
This is yours, yeah. So look at this. It was Luke Law, the phys ed.
Is this what you? Is this a study?
All right, I think we might try and get a start, guys. I'm glad that they're here. I'll call you up. Good evening. Hello. This on? Just wait for the last few to come in. A bit higher? Perfect.
And then I'll turn it down.
Okay. All right, guys, I think we're going to get a start now. Good evening. My name's Adam, and I'm anaesthetist at Charlie's. We might try and get started and catch up a little bit later. We don't want to be here for too late. I'd like to begin by acknowledging the traditional custodians of the land on which we meet today. I'd also like to pay my respects to ancestors and elders past and present. So first I'd like to acknowledge also our sponsors, as without them tonight wouldn't have been able to happen. So thank you to Michelle and Catherine from ICU Medical, Kate and Kiali from Duke Medical, Lydia and Alistair from Avant, Michael from Sonosite, and Lisa McMillan from Echo Therapeutics. Thank you very much for your support. We very much appreciate it and look forward to seeing you guys at future meetings. So some quick housekeeping. If you notice upon arrival, there's a QR code. Please scan it, both for your attendance as well as to give you a certificate for PDL at the end of the night. Toilets are outside and to the right. And feel free to stick around afterwards and continue having a chat. There'll be plenty more food and alcohol. So we'll aim for all the speakers to follow on one after the other. So just please leave your questions until the very end, where we'll have a bit of a panel at the end. And there'll be some roaming microphones for you guys to ask some questions. This is the third year since COVID that we've been running these meetings, and we'll continue to endeavour to run 2 per year. Looks like this September time is a bit better than November, so we'll probably keep it around this time. The next meeting will be in May, and will likely be a Fiona Stanley hospital-led headliner speakers, including a revisiting of lignocane spinals and a bit of an audit from someone's practice there, amongst others. And if anyone has any ideas for future talks, please get in touch with me at the end of the night. All the talks are recorded and will both appear as a summary in the WASORA newsletter, as well as live recordings being available on the website, which Dr. Shane Power does such an excellent job at keeping up to date. Thank you, Shane. So a couple of other community announcements. NR Fit has just recently been mandated by the Department of Health for all hospitals without a specific time frame. Anyone interested in this announcement, feel free to have a chat with Dr. Brian Hennessy regarding its origin, and I encourage you all to have a look outside at the NR Fit equipment from the sponsors outside. The Aracus course is this weekend. Thank you once again to Boyan and Dorian for organising the course. It's almost always fully subscribed. So if you're interested in doing it next year, feel free to get in touch with them. Ezra is on now, so you can't go to that. The African Society of Regional Anaesthesia and Pain Medicine with RAUK is happening next year in Cairo in November. The ASRA, American Society of Regional Anaesthesia, will be held in April of next year in Phoenix, Arizona. And yes, that's about it. So before I invite our first speaker to the stage, Dr. Chris Mitchell would just like to give a very brief update on behalf of Alex Wycherley regarding the PrEP check rollout.
Thank you, everyone. This has been a bit of a slow burn over a few years, but Alex from Fiona Stanley has done a huge amount of work trying to get this idea of PrEP check up, where the idea is that the stop before you block actually hasn't stopped wrong-sided blocks. And so he's put a lot of effort into trying to come up with a new system. The ANZCA have recently released a new, or about to release a new stop before you block, but it's a bit complicated because it's totally linked in with the check-in of patients as they are checked into the hospital. And as every hospital in WA checks patients in slightly different ways, it will mean there's a slightly different system in each hospital, and it also requires you as an anaesthetist to do part of the check-in with the anaesthetic nurse in the holding bay or as they come into theatre. So I've got a feeling their system's not going to work that well in Perth, and it's made me a bit more fired up that we try and have one system that works in all hospitals in Perth, and I think this PrEP check's the best go at that. So we're going to actively try and introduce it at Perth and Charlie's and all the other hospitals that I'm involved with. Alex is working on quite a few of the other hospitals, and I've got a few other people at Joondalup, Osborne Park. Haven't got anyone at Midlands yet, I don't think. But if you see this happening at your hospital, please get on board. It'll work best if we all get on board, so that if you go one hospital to the next hospital, it's exactly the same. And the biggest part of it is, I think, really getting the anaesthetic tech involved in a team, which means as you go to start doing the block, they're probably standing there with the consent, and you can at that stage go, yeah, the consent says right, I'm about to paint the right side. You paint the right side and do your block and move on. Anyway, we'll see how it goes. Thank you very much. Thanks. And thanks for such a big crowd. It's great to see I think there's 70 odd people here, so that's great.
Thanks, Mitch. And if anyone's interested, there's about 20 flyers of these printed out just outside if you wanted to guys take one back to your hospital, whatever that might be. Okay, so our first speaker is Dr. Brad LAWTHER. Brad is a consultant anaesthetist at Osborne Park, where he runs the pain service there as a busy private practice. He has a keen interest in regional anaesthesia and, by virtue of his talk, a keen interest in nerve catheters, particularly interscalene catheters. And he's here to convince us that ropivacaine works better than saline through these catheters. Welcome, Brad.
Thanks, Adam. Thanks for your perseverance, nagging, for me to come and present tonight. Really just going to talk about the post-operative management of pain in arthroscopic rotator cuff surgeries and the RCT that I've been involved in with POSM. Declaration of interest, well, we did get some institutional support from Hollywood Research Foundation, a little bit from the Shoulder and Elbow Society and POSM Research Institute as well. I'm certainly no academic. I'm a clinician, so you'll find that out as we go along with the RCT. I think it's pretty difficult to be both, but the next speaker, he can do both. So CURRIGAN is going to be next, and that'll be great. As far as we go, we'll just really keep it clinically slanted, and then I'll let you know how we went with the RCT. So we know shoulder surgery, certainly rotator cuff surgeries, are painful. We know it's in the immediate post-operative period. And we know if we intervene at that point, it affects pain control, it affects the rehabilitation, and certainly patients are more satisfied. But I thought we'd start with just a question, and it's something that's obviously in our minds all the time, is how long should a block last? And this is something that's often left to us as anaesthetists or clinicians. And we eyeball the patient, we do our endobetogram, make some assumptions, and go ahead with our single shot, plus minus adjuvants. And obviously, everybody wants to do their best. We all want to do our best for the patient. We want the best outcome for the patient. Ultimately, we want to win. Well, small margins in winning. But we need to think about what we're doing and how long what we're doing is going to last, what sort of duration we're going to get. And when we do that, we need to think about how long the pain's lasting. So there's not many surgeries that you're going to get pain for less than 24 hours. And even with your adjuvants, how long are you getting? So this is an interesting study. It's from Brian Ilfeld. Ilfeld is probably, he's a bit of the guru of nerve blocks from back in the day. And he looked, given it was a single institute and a single population group, but he looked at pain trajectories in a variety of surgeries, and he followed the patients up for at least 7 days, but also beyond. And if you just look at the sort of bottom right, just shoulder arthroscopy, because that's related to what I'm going to speak about, you've got 3 days of moderate to severe pain. Day 4, pain generator starts to tail off, and they do a bit better, but 3 days that we can intervene in. If you look at the knee arthroplasty, so top left, that's something we see all the time. They've got moderate to severe pain well past day 6, and we see that. So that's 2 weeks of pain. So the guys who are prescribing 3 days of slow release maybe need to think about that. Moderate to severe pain well into the 2nd week for knee arthroplasties. But for the purpose of this talk, shoulder arthroscopy, we're talking about 3 days of moderate to severe pain. So how do you see your pain management? Does one size fit all? There's the Tempus group, which is the temporal post-op pain signatures group. It's a guy called Patrick Tarr. He's from Florida University, and he did an incredibly interesting study. We looked across multiple surgeries, hundreds of patients, and he tried to identify pain trajectories, and he basically got 5 distinct pain trajectory lines of patients. And if you look at it, you've got this one group, the sort of big dotted line, you've got one group that just tails off really quickly. So they're really sore, and then the pain just decreases really quickly. You've got another group that's got high pain throughout. You've got another group that's sort of mid to high pain, and then you've got one that's moderate to low pain, and then this low pain group that just carries along. And the biggest group is the moderate to that, almost about 50% of this moderate to high pain group. And he tried to work out how do we identify which patients are going to respond to the pain in these distinct lines, and what does the pain resolution look like for those patients? And it turns out that he didn't find that the surgery mattered. So he looked across the board, from pancreatic to spinal to you name it, and there was no significant relationship to the type of surgery. Now, we've been told procedure-specific surgery, so your procedure-specific pain management, the prospectus group, and it makes a big difference. And it certainly does. So I'm going to talk about cuffs in a moment, and if you've got more than 4 anchors going into your cuff, lots of pressure, lots of fluid, they're going to be sore. So it plays a role. But in this study, it didn't seem to make a big difference. So we couldn't really elucidate what was causing the issues. So looking at characteristics was the ones we know about. So younger patients, patients with anxiety, depression, diagnoses, pain behaviours, catastrophizing, younger females. Those were all characteristics that they thought they could assign to a distinct line. But from looking at it as a whole, they couldn't really elucidate which patients were going to respond well to pain and which patients were going to cope with the pain resolution, which makes us think about how do we know? We're just eyeballing them often in private in a betagram just before they come through. How are we picking how they're going to travel? How are we picking how they're going to respond and what that's going to look like and what that means for the patient? So if you take a big patient population, we've got to decide which arm we're going to go with. So you can do a standardised approach. So you look at the punter and you decide, I'm going to go single injection. Single injections are fine. And I've heard that shared loads of times. Single injections are fine. And they are. So you're going to go single injection. Everyone's going to get the same thing. They're going to get my adjuvant that I add in, and they're going to get my multimodal plan, and that's fine. Or you can go, well, let's think of a little bit more tailored approach. So I'm going to put a continuous catheter in, and then I'm going to respond to how the patient travels. So I can do a greater intervention afterwards or less intervention. I can titrate it as and when and how I need to, because I know I actually can't elucidate which patients are going to go great and which ones aren't. Some of it's clear, so we can all pick the good ones. If she's just hopped off the flotilla with Greta and she's got purple hair and a pink unicorn fluffy, teddy bear with her, and she brought her own pillow, this is not going to go well. But there are the other ones that are a bit more tricky, and to have something that's tailored and titratable I think is the way to go. So for me, the gold standard is still the continuous technique. If you think about the acute pain service ward rounds, when you've got a continuous technique, you go and see them and you tinker. So if they got an insensate arm and they've been smashing the PCRA bolus the whole night and they've got this dead arm, then you go, okay, well, she's obviously anxious, or he's anxious, let's get back from the bolus, or let's make the bolus 4-hourly, or let's get rid of the bolus. And we do less. If we get there and the secondary block's not quite as hot as we would like it, we then bolus. We add a bit more massive drug around the nerve. We hope that resolves. We have a look at, what else can we add in? What other opioid-sparing techniques we can do? So we tinker daily on ward rounds all the time and try and get the best from it. I just think the continuous catheter techniques are something that's the best opioid-sparing technique. So if you're going to go pre-gab, clonidine, whatever else, gabapentinoids-wise, you're not achieving what you could achieve if you stuck a catheter in. And then I know there's those guys who go, it's fine, single shots are fine. And that's absolutely correct. They are fine. But the arguments are, well, it's time-consuming. It takes too much time. There's shared loads of studies out there from decades ago where they compared electrical stimulation to ultrasound, putting catheters in. And unless you're an outlier, most of them around the 10-minute mark. It's not that long. It doesn't take that long. You're there anyway with your primary block. Sticking a catheter in is not that long. Yes, it adds complexity and equipment issues depending on where you're working. And certainly if you're in a tertiary institution and you're teaching, that's obviously time-consuming. You do have to teach. So all those things do play a role. But I just think it remains for me the gold standard. And I'm not naive enough to say that, this is the way. You just put this catheter in and they're all brilliant, okay? It's a recipe. So it's one ingredient in your multimodal analgesic plan. So, for shoulders, certainly don't underestimate the value of the ice packs. Compression ice packs for shoulders, and it's a superficial joint, works like a bomb. There's people in the audience probably have had ice and gone, yeah, it was the best thing since sliced bread after the nerve block wore off. And then your normal analgesic plan that you have, along with the catheter, goes a long way. So with this in mind, we sort of were toying with the idea, and essentially there's lots of evidence now to show that the complication rates is very low. We're not having real issues with it's rare with the catheters, but obviously you get the benefit of long duration. You've got to think about, there's a lot of scrutiny now about our opioid stewardship, and what are we doing, what are we prescribing on discharge, and how are we managing that. So it was in the frame, but we hadn't really taken it any further. And then I do mostly orthopedic anaesthesia, so everything happens around a beer after work. And I should have just had another beer, but I didn't. And the surgeon basically said to me, I think that your catheters are working better. So I think patients, I don't do as many repeat prescriptions for opioids, and I think functionally, rehabilitation-wise, I think they do better. We should try and prove it. And silly boy, I bought into it and thought we'd do an RCT. So we thought what we'd do is compare interscalene catheters versus placebo catheter, a sham bag of saline. We do it randomized, double-blinded, and prospective, and then have a look at, does it decrease the pain? Your PCRA interscalene catheter, does it decrease opioid use? Does it allow or facilitate quicker rehab? And do we get improved functional outcome compared to placebos? So inclusion criteria was simple. So supraspinatus tear, diagnosed clinically and confirmed radiologically. They'd had persistent symptoms despite conservative non-operative management, and then they were recruited. Exclusion criteria, as in all these studies, we exclude the punters that really need the catheters, which always gets to me. So the ones that you think, easy, chronic pain, opioid tolerant, disaster, stick a catheter in this one, no, we're not going to use those ones. And that's just the nature of the literature. So we recruited 48, randomised to the control and the treatment arm. We had 3 punters who were withdrawn, 2 of them for medical reasons. So first one, his rebound pain was bad, and he had the sham bag, and took lots of opioids and went Delali, an old boy. So the next morning, to spare the opioids, we took him out of the study and we stuck him on a... And when I say we, I should really take the opportunity to thank Sinead O'Leary, who's here in the audience, because she did a lot of the legwork, and so did the acute pain service girls at Hollywood. So we changed it to ropivacaine in that case. And the other one was a punter we sent home with the sham bag, and he was obviously doing okay with placebo, and then got it home, fell in a hole, came back to ED. Sinead actually brought him into recovery at Hollywood, and then we bolused him and changed the bag. And the other one was, I can't remember whether this is the bloke or the lady who, she had it in her chair and stood up quickly and just pulled, I don't know how she did that, there's always one. She pulled it right out of the neck all the way around and the whole bag out the neck. So, but otherwise, everybody else was pretty good. So they both got general anaesthetics, interscalene catheters. So interscalene block, the primary block was 15 mils of 0.2% ropivacaine. And they both got the same, and catheters placed. In recovery, they randomised, so Sinead arrived with the little magic envelope, and Baxter provided these great little study bags, so you couldn't tell whether it was normal saline or ropivacaine. So researchers and patients blinded. And then they either got the placebo catheter infusion or the ropivacaine. Both had the same regimen, so 2 mils an hour with the 5 mil bolus and 1 hour lockout. And then they had breakthrough analgesia available, discharge on day 1, and the catheter was removed by themselves at home, and a follow-up call on day 3. So the outcomes we looked at was opiate consumption, pain, they kept a 7 days pain diary, and we looked at VAS pain scores, so frequency and severity. So pre-operatively for the 7 days, and then 2, 6, and 12 weeks. Secondary outcomes were functional outcomes, which is small numbers we had, but that was the one I thought, from a surgical point of view, that's what they were after. They did the constant score, which I'll go through in a bit, your Western Ontario rotator cuff score index, and then patient satisfaction was just a simple 4-point Likert scale we used. Surgical technique, the bonus was that we had single anaesthetist, single surgeon, single institution, slick surgeon, so non-absorbable anchors. He did a biceps tenodesis tenotomy if he was there and it required one, and a little bit of a chromioplasty, so a little bit of a decompression. Post-operatively, 6-week sling, pendular range of movement, which is, as the physio said today, it's rock the baby, not stir the spag ball, which I thought was an interesting way to look at it. And then wean the sling at 6 weeks, and then start your strengthening movements at 12. So what did we find? Well, there were no difference between the groups demographically. We didn't have any catheter-related complications, and the outcome measures improved. So from pre-surgery to post-surgery, the patients improved. So functionally improved. So our two groups, your single shot and your catheter, the patients are doing well. They're travelling well. Satisfaction rate, both groups, both happy, satisfied that their pain has decreased and their functions improved. The thing that was interesting to me was, if you look at all studies in the previous literature, there was always this big, large effect. So the studies are powered for small sample size because there was this large effect size. And I think with the possum guys, it was based on that input when we did the study. So small number, effect size, expecting a large effect size. And we didn't achieve that. And some of that's, you live and learn when you do RCTs. So some of that was because we tried to do an ethical study. We tried to effectively blind the participants and the researchers. And what we did was, in the past, so going back a decade when these sort of studies started, what they used to do is just give an anti-inflammatory, and then you had a catheter or single shot, and then you had a PRN opioid. And obviously there was a big change in pain. But obviously that's not the way we manage things now. So those of us that do single shots, you know, we're aware of rebound pain. We're aware of the analgesic gap. We manage it with extended formulation opioids. So most people are using a slow release formulation of some sort, which is what we did. So we decided to use a standardized pain management protocol for both groups, because obviously I didn't know which one was going to get the saline and have this rebound or suddenly get this analgesic gap. So they all got slow release tapentadol, both groups, and had IR for breakthrough. So there was the control used a little bit more, but not significant. And I think that was confounded by what we decided to do with our pain management plan. And basically, you know, we didn't sacrifice a patient. Pain scores, interesting. So day one, a reduction in pain severity on day one for the INTERSCALENE ropivacaine group. So the treatment group had lower pains. Now, it's probably related to the guys who got the saline had some sort of rebound pain on day one and then recovered, whereas the INTERSCALENE group just cracked along. The same change wasn't witnessed on day 3 when the INTERSCALENE catheters were stopped. But it was only on day 1 that we noticed that difference. Now, the discussion point from the surgeons were, if that's when we get the main effect, that's when everything happens. So for them, that day 1 morning is the first encounter for the patient with the physiotherapist, the first encounter of the surgical follow-up with the surgeon. So if you've got someone who's got a lower pain score and is switched on, that facilitates the chat about what this rehabilitation is going to look like, what the physiotherapy looks like. They're engaged, and they felt that was maybe making the difference in the outcome down the road. If you look at the differences in severity of pain and frequency of pain over from pre-surgery to 12 weeks, there's no real difference. They all travelled well, both groups doing good jobs basically, and at 12 weeks they were both pretty good. The constant score is a surgical score. It's basically subdomains. There's pain, there's activities of daily living, and then there's range of motion and power, which the surgeon looks at, and it's a score out of 100. And then he compared to pre and to post-surgery, and there was a difference. But your minimally clinically important difference they allocated, we didn't quite reach that. So statistically, yes, but didn't quite reach it clinically. Although, because of the small numbers, the surgeons felt like potentially we are making a difference. You need big numbers to prove that. The other one they look at is the Western Ontario rotator cuff score. And again, they have these sort of subdomains: physical symptoms, sport, recreation, work, lifestyle, and emotion. So essentially, lifestyle is your shoulder limiting your sport or your recreation or whatever you decide to do. Emotion, the question is like, are you down in the dumps because of your shoulder? So questions like that, and there's a few of them. And again, if you look at the pre-ropivacaine to the post-ropivacaine, there was a clinical improvement in all outcomes. And certainly no statistical significance, but we're on the right track. So although not as marked a difference as we'd hoped, there were strengths in the study. So standardised to single surgeon, single anaesthetist, single institution, the same POSSUM group for follow-up and rehab. Confounding factors, which we'll talk about in a second. The blinding worked well. Limitations was that we had that standardised approach to the pain management. And I still would have been uncomfortable. I mean, I've looked at a lot of the literature now and seen the guys who do the continuous and the single shot and just go with PRNs. So the single shot or the sham catheter, they've got this obviously drop off of the block, and there's wear off, and then suck it and see, ask for the PRN opioids. And then you're chasing your tail. So you've got nothing managing the analgesia gap. And of course, the pain scores are higher, the opioid requirements are higher. That's not what we do anymore. We don't do that. So managing the single shot well with the slow release seems to make a difference. And thinking about how you're going to manage your rebound pain. So that was certainly a limitation as far as the powering of the study, because we didn't have the large effect. It did give us our powering gave us a nice small sample size we needed, which is great, because if you do an RCT, you realise what a pain in the arse it is. And so that was good, but didn't get the result we wanted. The other thing was, and a lot of chat around this, is invasive placebos, so sham catheters. Should we have used the sham catheter? Is there benefit? The sham score was low, so complication risk for the patient was low. So we went ahead and used the sham catheter. Now, that's another confounding one, because you've got patients who've been managing these nurses who've been managing these patients on the ward for ages. And their go-to is, if you saw in the night, press your button and you'll feel better. So there's positive reinforcement of the placebo. And we certainly had a couple of old boys who I was convinced, I remember saying to Sinead, he's definitely got the good stuff, man. He's telling me how awesome that placebo is, but I think he's got the good stuff. And then later on, I find out it's placebo. He's either off his chops, or he's 72 and he pressed that button, or the nurse was very attractive. Whatever, he was using the button and it was working. So there was that was a bit strange. The other thing is that Brian Seitz has done a bit of study into this as far as saline boluses in themselves with the sham catheter. There's some sort of theoretical ideas and some animal stuff that potentially by giving saline, so if he's sore and he's got a sham catheter and he's smashing the button, he's putting in saline boluses, and that in itself causes a bit of pressure. You get some pressure on the nerve fascicles, some axonal ischemia, and is that affecting transmission of the nerves as well? So there was this sort of stuff that's all out there. So in conclusion, what did we show? Well, improved post-op day 1 pain severity score, and improved constant score at 12 weeks. And certainly there's great satisfaction rates across both. There weren't any adverse effects. We didn't demonstrate any statistical difference in the overall opioid consumption, but it seems that potentially we got adherence to rehabilitation and the planning for that and the expectations early on because of the low pain score, and maybe that's suggesting we got improved outcomes. So I'll finish with this. This is Bob, and this is for those single shots are fine. So on the left is that's day 0. So Bob is the first out of the rank because he's a bit crumbly. So he gets a cuff repair at 7:30 in the morning in theatre, and he goes to the ward after a single shot, no adjuvants, and he's given a PCA. So the guy's done the blocks, thought about it and gone, we'll probably cover him because block's going to wear off at some point. We give him a PCA. Anyway, block wears off, he gets massive rebound pain and he smashes PCA to the point that he's sort of unconscious. Anyway, a little bit of a vomit, and he aspirates and met call, and he gets shifted to HDU, and they call me, and that's who I see. I see Bob with the vomit bag and on high flow and pretty naff. Anyway, we stuck a catheter in him, and that's Bob on the other side in the morning. He's smashed his breakfast because he hasn't eaten for like 2 days. He's got a great smile, thumbs up. He's in the sweet spot. So he had the tingly thumb, shoulders pain-free, C6 is still working, C7's definitely working, and the hand's working. So he was great, and we actually ran that for 4 days for opioid sparing. And if that doesn't convince you, then this cheesy smile must, because in March we started getting paid for these bloody things. So up until now, I've sent over 1,000 patients home with catheters and got nothing. But now there is an item number. So MBS has come to the party, 22032. If you didn't know that, from March you can get some money for it. So that's another reason to smile and put catheters in. And that's it. Thank you very much.
Thanks, Brad. There were 2 things I learned from that talk. 1 is nagging you works. 2 is if Greta Thunberg is on your list, either put in a catheter or call in sick. Our second speaker is Dr. Dale Currigan. Dale is an anaesthetist at Charlie's and gets bored very easily. When he mastered regional anaesthesia, he went into the research realm and became departmental research coordinator. When he completed his Masters of Echocardiography, he then decided to become one of those cardiac anaesthetists. Dale is here to tell us about a controversial new trial at Hollywood Private Hospital comparing high-dose dexamethasone in total knee replacements. Please welcome Dale.
Perfect, thanks. Thanks very much, Adam, and thanks everyone for coming along tonight. First of all, to the Charlie's anaesthetists, just to let you know you've earned yourself a sleep in, because I'm giving this exact same talk tomorrow morning, so unless you really enjoyed it and want to hear it twice, please sleep in. Another shout out to Brad and Connor, because if you find this talk a bit dull, you've really got them to blame. Let me just read for you a little note from Adam. Sorry, I've just lost it. June 23rd. Hey mate, Connor Brad mentioned you wanted to give a short 20-minute talk on 1 milligram per kilogram IV DEX study. Thursday 11th of the 9th work for you? That's really funny, guys. I just don't recall having that conversation, but nevertheless, I'm here and I'm giving this talk, so take from that what you will. Yes, let's get into it. So, for those of us that do knee arthroplasty or look after patients post-knee arthroplasty, we know that it's a really painful operation. which is also quite eloquently described by this review article here. It has a lot of pain, a lot of swelling, and it can be quite a challenging operation to get the analgesia right. There's really quite a profound inflammatory response with total knee replacement, and there's good evidence for quite an inflammatory storm with raised interleukin-6, interleukin-10, CRPs, tumour necrosis factors. So all these factors lead to quite a degree of inflammation, pain, and patients do really struggle. I think in the 10 years that I've sort of been looking after these patients, I have seen quite a progression, and I think we've done pretty well. We've gone from epidurals where patients are comfortable but can't move, to femoral nerve blocks where they're maybe a little less comfortable but and still with a motor block, and then onto adductor canal catheters where we've got quite a good balance there on top of our multimodal analgesia. I guess the question is then, what's next? So apart from my work at Charlie's, I also work as part of the acute pain unit at Hollywood, and it's a really busy job, as the APS team here will testify to. I do a Friday, we'll commonly see over 50 patients in a round, and 80% of that would be arthroplasty. And it's so busy that I don't even see the hip arthroplasties, it's all the knee arthroplasties. They're the difficult ones, and they're the ones that need a lot of input. So seeing that volume of patients, it really doesn't take long to see some patterns. You get a good feel for who's going to struggle and who won't, what works and what doesn't work. So if something changes, you kind of get a bit of a sense of what's happening pretty quickly. So about April, May this year, I started noticing on some of the referrals high-dose dexamethasone, 1 milligram per kilo on the referral sheet. And I was like, okay, that's interesting. And we'd go and see these patients, and then I'd look at the anaesthetic chart, 80 milligrams of dexamethasone. Okay, that's a big dose. Anytime you need to get out 10 ampules of a drug to administer it, you're probably on the higher end of the dose range. And I guess my first thought was that this is completely nuts, that we are giving a massive dose of steroid to a patient with a brand new knee prosthesis, and we're going to suppress their immune system. They're going to have infections. They're not going to sleep for a week. They're going to be psychotic. Their blood sugars are going to be out of control. What are we doing here? What's going on? That was my initial feeling anyway, but where this really stemmed from was a couple of the surgeons had visited a centre in France that essentially was trying to do day surgery knee arthroplasty. And looking at their protocol, what it really was for the most part just pretty standard ERAS principles. But what was a bit different was the inclusion of this 1 milligram per kilo dexamethasone. So that's where it came from. They were really excited about it, and I guess I sort of thought, okay, let's see what we've got here. So over the subsequent weeks, I have to say I was quite surprised at how well some of these patients were doing. I was definitely seeing a change in the pattern of recovery. Patients still had pain, but their functional outcomes were much better. Some patients were absolutely amazing, where previously we would not have seen that level of analgesia. And it started to make me think that while this seemed crazy, maybe there was something big here, and maybe we need to know more. So really that's where this comes from. And I must say, I'm not trying to sell this in any way. I have no vested interest. I don't even really do any orthopaedic anaesthesia anymore. But it's an interesting idea, so I'll take you through our journey so far with it. So I guess when you hear a crazy idea like this, probably your first thought is, okay, well, there's got to be something in the literature about this. So you go and do a little bit of a literature search. There's a lot of studies looking at DEX in arthroplasty, a great deal, in fact. And there's really what I decided I wanted to know was, okay, does it improve pain? Does it improve functional outcomes? Does it change the trajectory of recovery? And what sort of adverse effects might it be associated with? So I turned to the existing meta-analyses, and there's actually quite a lot of these as well. Many have quite a lot of methodological flaws, grouping together bilaterals and unilaterals, hips and knees. Anyone that sees post-op hips and knees will know they're vastly different recovery profiles and operations. So the two that I've picked out here, I think are the best methodologically, and I will refer to them in the future. But these essentially look at all-dose dexamethasone. So the vast majority of these studies are looking at 4 to 8 milligrams. And what I found was there's a bit of a literature gap instead in terms of a review of the high dose range, which is what I was interested in. So what I did was what I've termed a solo systematic review. So normally a systematic review, you would have multiple reviewers so that you kind of reduce the bias that you might otherwise have. But I've just undertaken this myself just to get a bit of a sense of what signal we have out there. So my criteria, we only wanted to look at randomised controlled trials. I only wanted to look at primary and unilateral knees. And then I wanted to look at a high dose range. I've sort of somewhat arbitrarily picked 16 milligrams, just because that's sort of double what we would otherwise probably give. And it also seemed to be a bit of a gap, division in the literature in terms of the dosing. So looking at doing a literature search, we came up with really eight articles that fit that criteria in that high dose range. So these are those 8 articles. So a bit of a mix. So at the lowest end, we've got a few studies using 16 milligrams. Some of the older studies used methylprednisolone and sort of commonly recognised conversion for 125 milligrams of methylpred is 25 milligrams of dex. We've actually only got 2 studies by the same authors looking at that 1 milligram per kilo, so I'll come back to that point a bit later on. All studies used a pain-related primary outcome as their main endpoint. This is a breakdown of what endpoints I picked out based on those criteria that I spoke about earlier of things that I was trying to identify. So a fairly good, fairly large patient numbers altogether. In some endpoints there was only 1 or 2 studies looking at that, so I wasn't able to really combine it for a meta-analysis. But overall, the sort of general take-home is there's quite a bit of heterogeneity in the literature, as per the I-squared values there. But I'll go through these anyway and describe what we found. So first of all, looking at the pain endpoints. So this is the forest plot of my meta-analysis, looking particularly at the pain scores at rest. So on day 1 post-op, demonstrated a mean difference on the VAS of 7.29 points, statistically significant. So look, there's definitely a difference there based on this literature in high-dose dex, but 7.29 on a scale of 0 to 100, you may be questionable of what clinical important difference that is. I've compared that to this study by Koppen et al., who looked at all the DEX studies together, and they report a fairly similar effect size. Importantly, the confidence intervals for my and their studies overlap quite significantly, so any numerical difference you can see there really is very unlikely to be of any statistical significance. The pain was much less on day 2 and similar to what had been previously reported in the literature. Moving on to pain with movement, probably a more substantial effect there. We almost achieved kind of 1 point difference on a scale of 1 to 10. Maybe that may be of clinical significance, and also somewhat similar to the overall DEX cohort. And again, day 2, things drop. In my analysis, I also, because of the fact that these studies use different doses of DEX, I included a meta-regression for each of the endpoints to try and identify whether the dose used was potentially an explanatory factor for the difference. And in this instance, on the day 2 pain scores, it was thought to be potentially significant. Moving on to opioid consumption, again, it seemed to be a small difference there. This is looking specifically at intravenous morphine consumption in day 1 and day 2. there seemed to be a dose-related effect as well for the high-dose patient. So it may be that the higher dose range does have more of a benefit. Knee flexion, I was a bit disappointed because I really wanted to look at the functional outcomes, but unfortunately in this high-dose range specifically, there's actually very little data comparing the difference in functional outcomes. So there was a single study that reported day one knee flexion in terms of range of motion that was not statistically significant between the groups, and 3 studies that looked at day 3 knee flexion, which did show a difference of about 10 degrees. It's probably of little surprise that DEX reduces your incidence of post-op nausea and vomiting. I think that's pretty well established. It did seem that perhaps there's an additional dose-related effect because the odds ratio for our for PONV in the high dose DEX group was significantly greater than the meta-analyses looking at the overall cohort. I guess, yeah, certainly one of the key adverse events that came to my mind first was infection and inflammation. So there is again a very clear indication that dexamethasone reduces your CRP. So high dose dex on day 1, there's a mean difference of 22 in terms of the CRP concentration, and really quite profound difference on day 2. So a mean difference of 73. So how that correlates to pain and swelling is no one can really say, but there is a clear difference in the manifestation of inflammation biochemically. Of course, hypoglycemia I really wanted to look at. Unfortunately, while a number of studies reported sugar-related endpoints, they all reported them in very different ways that made it impossible to pull the results together. But a couple of key points just to rule out. There's a very clear signal that sugars are higher in the DEX group, so there's no doubt about that. And so the incidence of hypoglycemia in this study by Cheng was higher, although not statistically significant in the DEX group. In the study by Chan, while there was quite a significant increase in the blood sugars, so almost 40% from baseline in the DEX group, when they compared patients that had wound infections and looked at their sugars, there was no difference in the hypoglycemia didn't increase the likelihood of developing infection. So yes, onto infection. So reassuringly, if anything, the odds ratio for infection across all these studies, most of them reported infection endpoints, was actually reduced. Not statistically significant, but certainly not any higher than normal. And a similar signal was seen with the lower doses as well. So I guess we know from the PADDY trial, big randomised control trial by Thomas Corcoran, that DEX does not increase infection, but it's hard to translate that to this high end of the dose range. So reassuring that at least the signal in the literature is that we don't see an increase in infection. This study didn't make my meta-analysis because it's not an RCT, but I think it's worth mentioning because it's a really big cohort. So it's a Danish study, almost 4,000 total knee replacements, and about 1,500 of those received a high dose of steroids, so equivalent of about 25 milligrams of DEX. So it was a retrospective retrospective registry review, and they showed no difference in the rates of infection between patients that did and did not receive steroid. And interestingly, the proportion of patients with a hospital length of stay greater than 4 days was actually much less in that steroid group as well. So retrospective study, but that does give me some reassurance with regard to infection as well. And just to finish off in terms of that literature review, sleep quality somewhat better with the dexamethasone, which I think is reassuring as well, because we sort of think, oh, give them a big dose of steroid, they're not going to sleep. It's going to be difficult. I think in some ways maybe if your pain's a bit better, your swelling's a bit less, you may in fact sleep better because of that. And pretty clear that no difference in hospital length of stay. So my sort of summary, I guess, what do we take from all those numbers and 1,000 forest plots? I guess probably from the literature, I was a bit underwhelmed with the size of the signal, the size of the effect size. I was sort of expecting to see something a bit more. There's definitely a signal there, but is it clinically significant enough? I'm not really sure. So there is some evidence of benefit, but I also couldn't really demonstrate a benefit in the high-dose DEX group compared to the normal dose DEX group. The functional outcomes were also very sparsely reported, so I couldn't really comment on that. Importantly, there was only 2 studies looking at the high doses that we're seeing used at Hollywood at the moment, and quite a lot of heterogeneity. So just to quickly pull out those 2 high-dose studies and look at their results. So the first, they're by exactly the same research group. They're essentially exactly the same trial, but just in different patient cohorts. So the one on the left, they termed patients with who were high pain responders. So they had high pain catastrophizing scores, or they were already on opioids coming into their knee replacement. And they were randomised to either 0.3 milligrams or 1 milligram. You'll notice the 0.3 milligram, by my definition of high-dose DEX, would actually put you in also a high-dose range. I still elected to include this study because I really wanted to see whether the effect was increased by that really high-dose range. So their results were quite favourable, that the proportion of patients with moderate to severe pain was much lower with the DEX. When they ran the same study in low pain responders, so having a low catastrophizing score and not on opioids, they were unable to show the same difference. So whether the DEX in that, there's no difference between that 0.3 and 1 milligram per kilo, we can't really say, or whether it was just related to those patient factors. So why don't we bring things back home then and look at what our experience has been locally. So I have to thank Mark Lennon for giving me some of his data to present tonight, and thank you to Emma Comerford for presenting these slides, for preparing these slides. So this is a small audit of Mark's, and so they're all his patients. I think a single surgeon, and he compared 25 patients pre and 25 post, giving this 1 milligram per kilo DEX. So he gave his fairly standard anaesthetic technique. He gave a milligram per kilo of DEX, and he gave his standard discharge analgesia. He routinely gives the patients a questionnaire for a quality of recovery score, and he also asks them how much tapentadol they've been using at 2 weeks. And these are what he found. So he did find a difference in the quality of recovery score. So essentially, if you're not familiar with that score, it's a 15-point score. Sorry, 15-question score. The higher the score, the better that your quality of recovery, and looking at a multiple domains. So it's been validated in the literature that the minimal clinically important difference between groups is 6. So Mark demonstrated a 14-point difference, so substantially different between the 2 groups at 2 weeks. Looking specifically at pain scores, now this is a little bit confusing because the scale's kind of round the wrong way. So this is not pain score in terms of what's your pain score right now, rated between 1 and 10. It's how much of the time do you have moderate pain, none of the time to all of the time, and how much of the time do you have severe pain, none of the time to all the time. So the moderate pain was about the same between groups, but he did show quite a significant difference, to, even though this is a small cohort, in terms of the amount of severe pain that patients were experiencing. He also showed some moderate benefits in terms of sleep quality and ability to perform activities of daily living. The opioid consumption was also down, but there was quite a big range in terms of variability within the cohort. So his summary was that there's overall better quality of recovery in this group, and it looks like a trend towards lower opioid requirements. He sort of used the term that not all patients are responders, and I would say that's been my experience as well, that we still have some patients that struggle a bit, and whether that's patient factors or other factors, it's impossible to say, but not all patients just fly, so you can't, there's no guarantees. And importantly, no significant adverse events. I'll also just compare that to a slightly different audit that we did as the pain service at Hollywood. So we did a very similar sort of pre and post audit. So this was a single surgeon, and we looked at 40 of their patients before introduction of DEX and 40 afterwards. That surgeon is fairly busy and has 4 different anaesthetists that work for him, but have a fairly similar technique altogether. And we did this just to reduce confounders, of course, using a single surgeon. So we only looked at primary unilateral knees, so no revisions or bilaterals. And because it was all retrospective, we tried to keep things as pragmatic as possible and only really collect things that we thought was going to be reliable. So these are the group characteristics. So a couple of things that I've highlighted here just to pull out. So spinals, there was initial thought that maybe they would drop the spinals altogether and just do GAs, but I think they fairly quickly decided that spinal is still a good way to go, even if you're using DEX. So there's a slight difference there, but overall not much. They decided to completely drop the adductor canal catheter. So all but one patient in the post group had no ACC, just a single shot block. Obviously the DEX dose is substantially different. And in what will become quite apparent in a moment, the PCA numbers are very important. So in this cohort, every patient that had a PCA had it because that was part of that anaesthetist's standard post-op analgesia plan. So none of them had them as a rescue technique, and they were all just part of the routine post-op plan. However, one particular anaesthetist in between the pre and post group decided to stop giving PCAs, so they ended up with almost double the amount of PCAs in the pre-group, but that doesn't represent, it does not reflect an increase in pain in those patients. So these are the pain outcomes that we looked at. So as I said, we wanted to pick things that we could reliably pick from the notes. So opioid consumption, we had medication charts there with times and dates so that we could reliably record opioids in each 24-hour block after surgery. We only recorded pain scores as the highest recorded pain score on a given day because anyone who's tried to do an audit previously would recognise that the way pain scores are recorded in the medical record is pretty haphazard. So, as a kind of, trying our best, we just picked the highest number that was reported during that period. So on the first day post-op, there did seem to be a significant difference in the amount of opioid. Even once you adjusted for weight, that was seen as well. But not really any difference overall in terms of statistical significance, but there is a numerical significance there in terms of a whole rating less on the first day. These are just the box plots of the same thing, looking at opioid pre and post. So yes, we included SR, IR opioid, PCA, and also included any intrathecal morphine that the patients may have had. Now, while the difference there seemed quite significant, what we found was that when you looked at the proportion of patients that had, or when you looked specifically at patients that had been given PCAs, their opioid use was off the charts more. So, surprise, surprise, if you give someone a device with a button and say, press this, and if you want analgesia, they'll do that quite a bit, especially because, you know, going into a knee replacement, these patients have been told by everyone they know how painful it's going to be. They've been told to take any analgesia they're given. So you give them a button, yep, they're going to hammer it. And that's exactly what we saw. So this is the combined cohort on the left. And then even if you break up the pre and the post, anyone with a PCA just smashed it. So that was obviously a big confounder. So we can sort of correct for that statistically, which is what I've done here. So this is a linear mixed effects model to account for PCA. Even once I accounted for the PCA use, there was still a statistically significant difference for that 24-hour time period. So it seemed like that at least in the first 24 hours, opioid consumption was less. The functional outcomes is where I think really is the game changer. Now, when I had all the paper forms that Sinead had worked tirelessly to collect and wanted to put them into a spreadsheet, The pain stuff, I was like, okay, that's fine, putting all the numbers in. As soon as it got to the functional stuff, I only had to go through a handful of forms, and I realised there was something quite substantially different here. The functional outcomes were really significantly better in the post group. So knee flexion was immediately better, even from day one, and the final flexion at physio discharge. So just to explain a couple of these endpoints, we're able to record these fairly accurately because the physios have to record these as part of the pathway. So they have to record the daily knee flexion, whether or not they are able to walk 10 metres. And then when the other discharge goal, they're discharged by physio, means they'd met functional independence. They could walk unassisted, they could use crutches, they could do steps if they needed. So knee flexion substantially greater. In the pre-group, only 50% of patients were able to walk 10 metres on the first day. All but one of the patients in the post-group was able to do that. Quite a significant improvement there. And then again, for such a small cohort, we're able to demonstrate a whole day earlier discharge by physio and a whole day less in hospital. And while this is a retrospective audit, and I accept that, and it's a small cohort, I did find that quite a substantial finding. So summary of all of that. So we did sort of suggest that opioid consumption was less, but not maintained. And my overall feeling is that the real gain here is in the functional outcomes and not in the pain and analgesia, although there may be some benefits. Anecdotally from the surgeons, they're just raving about how well these patients are doing post-op. This is, of course, not scientific. It's just their excitement over the whole thing. But they're, sending around videos of patients who are walking around like they've had no surgery after 2 weeks after bilateral total knees. The other thing that I find exciting is that they're telling us that the repeat opioid prescriptions have virtually dried up. And I think from a sort of public health and opioid stewardship point of view, if we can actually make a big dent in that, that would be really something quite special. So final points and where I think we go from here. So to quote Brad, Dex is not an analgesic. I think that's important to remember. It isn't a painkiller. But if we do reduce the inflammatory response, then it probably follows that there will be less pain. It does seem that not everyone is a responder, but some patients just seem to do amazingly. I think functional outcomes is where things are going to be. Overall, some encouraging early signs, but I wouldn't necessarily take this as a signal to go out and just start giving everyone a milligram per kilo of Dex. I think we need more evidence out there, especially in terms of safety. So we are at the moment in the development stage of an RCT. So the plan is to have a 3-arm trial comparing a standard care dose of 8 milligrams to 0.3 and then 1 milligram per kilo. Have a functional outcome as a primary endpoint. Look at long-term outcomes as well as pain and opioid outcomes as well. So watch this space anyway. I think there may be something here. Thank you.
Thank you, Dale, for agreeing to give the talk that you didn't agree to do in the first place. I'm sure that will generate many questions soon. Our final speaker is Ms. Jill Kemp. Jill is one of the CNC APS nurse extraordinaires at Charlie's, who keeps the APS team afloat. She will be giving us an insight into perioperative lignocaine infusion usage at Charlie's. She has braved it all the way here to give us a talk despite being recently unwell with an ongoing cough. It's great to see so many of the APS nurses here tonight from both public and private. You guys do a fantastic job in looking after our patients post-op, and I have no doubt that you will make a significant difference to our patients' post-op recovery. So thank you very much for that. Please welcome Jill. Need more water.
Where do I find my talk? Actually, no, I think I will have the, hang on. Hello everyone, thank you very much, Adam. And I have a very similar story of persistence and begging from Adam that's actually got me here tonight. So thank you so much to all of the nurses who are here tonight. Can I just get everyone to wave so I just know where you all are and I can just look at you all in the crowd as I speak. I'm looking forward to more nursing talks at these events. So when Adam first came to me and asked me to do a talk, I thought I don't really have very much to contribute on the subject of regional anaesthesia or analgesia. And so I thought, thinking about local, acting globally, why don't I talk about the Sir Charles Gairdner experience of delivering intravenous lidocaine infusions for acute pain on the ward, which is not something that a lot of places do. I think at the time that we started to consider doing it, one other major Perth hospital was running intravenous lidocaine infusions for acute pain on the ward. There might be more now, but I'm not quite sure. Thank you, before I forget, thank you very much to the nursing team in the acute pain service. I've got Cody, Deb and Candice here tonight. Lisa's unfortunately not able to be here. They're the ones who are the backbone of the service. They keep everything running. They're the ones that I'm going to turn to at the end of the talk to ask if I've actually forgotten anything. Hopefully they won't bring up anything I've left out accidentally. And thank you to all of the wonderful anaesthesia consultants and registrars that we work with as well. So, horror of horrors, every now and then, a pain comes along that you can't block. Inconceivable. Either it's too intracranial or a patient's too bleedy or for whatever reason you can't block it. It's not, it's can't use a regional technique. And so the trick for us, for the anaesthesia consultants, namely, I think one, Dan Elliard, had a lot to do with it. Is Dan here tonight? No. Was convincing the nursing staff and the nursing SRNs in charge of hospital policy and nursing practice guidelines that it was safe to run intravenous lidocaine on the wards. And it was effective and it was useful, which of course we know it is. It's a fantastic analgesic agent. It's got the anti-inflammatory and the anti-hyperalgesic properties. It's a great little rescue agent. There's evidence for its use in abdominal surgery, spinal surgery, for its use in chronic pain. We see it used a lot there. In patients with hyperalgesia, in patients with severe acute pain, particularly where there's a neuropathic element, and a little bit of evidence for its use in headache. So, is it safe? Yes, at the time that we were considering running ward-based lidocaine infusions, the anaesthetic doctors were giving boluses and running infusions in theatre. Chronic pain, we're using high dose or solid dose infusions over short periods of time in the chronic pain clinic. And we were running continuous infusions in the intensive care unit, which was our default monitored area, with the stipulation that we top out at 1.5 milligrams per kilo per hour with continuous monitoring, maximum of 3 days, which eventually turned into a big old begging session to let them keep our patients a little bit longer because of bed pressures. And also we knew it was safe because another tertiary hospital at the time was actually using intravenous lidocaine on the wards, although they subsequently stopped using intravenous lidocaine on the wards for their acute pain due to the number of side effects that they were having, which is something that I'll get to later. And we knew that other centres were using intravenous lidocaine as well, so that as nurses, we could be sure and we could convince our colleagues that it would be safe to run intravenous lidocaine, mainly me, convince me, on the wards at Sir Charles Gairdner Hospital. And so we started. Dr. Elliard wrote a protocol. He wrote an anaesthesia protocol and he wrote the nursing practice guidelines protocol. we called it the IV lidocaine for acute pain protocol. I took it to the Nursing Practice Guidelines Committee. They hummed and hawed and asked lots of questions, and then eventually agreed to let us try it. So we agreed at that time that we would always commence our lidocaine infusions in a monitored area, which I knew would be fine because most of the lidocaine infusions we would be commencing would be started in theatres on all the back patients, and we wouldn't ever have to start them ourselves, so it would be fine, and that turned out not to be a thing. The initial bolus would be given by an anaesthetist up to 1.5 milligrams per kilo. The infusion would be topped out at 1.5 mg per kg per hour. We'd give twice daily anaesthesia reviews. We would have safety elements in place. So we had these very safe pre-mixed bags, which we were told would be 2,000 milligrams in 500 mils, so nice and safe. We would keep the infusions to 2 wards only. And we would have an infallible drug library in our pumps from which nothing could ever go wrong. And we would always, always, always stick to our solid rule of maxing out at 24 hours and stopping the infusion after 24 hours. So those were our rules, and we knew that we would keep the patients safe. Going forward, excuse me, to look at our outcomes after a period, or an eon I call it, of 19 months, I gathered some data together and we'd managed to deliver, well, we gathered the data, managed to deliver 19 infusions to 16 patients. We had 3 episodes of repeated infusions. In the 16 patients, 5 of those were patients who'd had neurosurgery, brain surgery, or one of them, I think, had had a subarachnoid hemorrhage with lots of vasospasm, which was surprisingly effective. 3 had had spinal surgery. All the spinal surgeries that we were using lidocaine infusions on were all very big multi-level surgeries, also cancer surgeries. Patients had a lot of pain and opioid use prior to those. Abdominopelvic pain, we had 3 patients who had had theatre, who had had regional or neuraxial techniques around perioperatively, but subsequently failed to progress with their analgesia, and we needed to use the intravenous lidocaine as a rescue. The 4th patient was somebody that had had an ovarian cyst hemorrhage 2 weeks prior, that we decided we'd tried all the other multimodal analgesic agents, lots of neuropathic agents on, and IV lidocaine was our last-ditch attempt. The 2 neuropathic pain patients that I've listed there are patients, one of them was a patient with trigeminal neuralgia, but, excuse me, the other patient was a lady with herpes, I'm going to get this wrong, herpes ophthalmicus, and we think a V1 neuritis. And we gave this poor lady everything that we could possibly give her: ketamine, methadone, the TCAs, the gabapentinoids, absolutely everything. Nothing worked, but we gave her 24 hours of intravenous lidocaine. Magic stuff. She begged us to keep going with it, but we actually had to stop it. She was one of the repeat patients because come a few days later, Dr. Eliard was doing the round and he decided to redo the infusion. And I don't think I was on that day because he decided he'd run it for 3 days, even though we'd undertaken to the hospital that we'd only run them for 24 hours. But that's fine, because what we discovered as the infusion ran longer and longer was that her pain shrank, and the ice pick that was going through her eye actually went away. And we started to see that longer infusions would be safe and could have more benefit. Another couple of lessons that we did learn were that not most of the infusions were started in theatre. Most of the infusions ended up being started by us in recovery, which was an awful process whereby we'd have to ring recovery, beg for a bed, take the patient down, big process, big palaver, set them up. do the monitoring for 2 hours, take them back to the ward. I don't know whether there was any placebo value in that, maybe the big process helped the patient feel as though the infusion would be more effective. It was just very disruptive. And the pre-mixed bags, if anyone would like to run IV lidocaine on the ward, they are not 2,000 milligrams in 500 mils. They are the most bizarre strength. It's still 4 milligrams per mil, but it's a bizarre strength, and I wouldn't recommend using them. So for auditing, we chose not to use any numerical scores at all. We chose simply to look at the patient's functional activity scores. We used the A, B and C score, where A is the patient's pretty functional with their pain and C is the patient's pretty dysfunctional and can't do very much. And just a word about my auditing. My data was catastrophically messy, and so I wasn't really able to extract a great deal from it, other than we seem to have a slight improvement in patient function. Most of the patients that we started on intravenous lidocaine had actually received methadone as well. Methadone's a rescue agent that we use quite commonly at Charlie Gairdner's, and calculating oral morphine equivalent in a patient that's received methadone proved actually a little bit too complicated for my little brain as well, but there appeared to be a slight decrease in OME. But the most important thing for me was there were no significant side effects. Patients had their infusions stopped for a bit of tingly lip, a little bit of facial numbness, but on the whole, nurses were catching these really early warning signs, stopping the infusion. The patient had improved, and we were doing some good. We were noticing that longer duration seemed to have better analgesia, no increased side effect, happier patients, and this was particularly so with neuropathic pain. And so we decided to embark on phase 2. So Dr. Elliard got out the pen again and made some changes to the nursing practice guideline and the protocol. And the changes that we made were that rather undertaking to start in a monitored area, we would just start our intravenous lidocaine infusions on the wards. The nurses do an ECG. The anaesthetist gives the first bolus up to I think it's 1 milligram per kg. Once the infusion starts, we do 5-minute OBS for 30 minutes, and then the infusion can run for up to 3 days at up to 2 milligrams per kg per hour, with twice daily anaesthesia reviews, and can run on any inpatient ward at Charlie's, provided it's G block, which is the main sort of building. We have some buildings that are a little bit further down, but we don't think they're particularly safe to run to out of hours. So those were our changes, and where we're up to is that in half the time basically, that we managed to capture 16 patients from our previous time frame, we've now managed to capture 31 patients. We've not had to repeat the infusion on any patients. We've still had no significant side effects. We've had the facial numbness and the tingling, the numb tongue, the heart rate, blood pressure changes. Whether that was related to local anaesthetic, I'm not sure. But we haven't had any significant side effects. And every time the nursing staff have to stop an infusion because they're worried that the patient's got a numb face or a numb tongue or tingly lips or whatever, that's absolutely fine. The worst that can happen, the nurses know that the worst that can happen is the patient's going to get a review, they're going to get the all clear, we're going to restart the infusion. The best that can happen is they get told they've done a really good job, like our safety mechanism has kicked in. Our applications have changed a little bit. We haven't done quite so much brain work, 1 subarach patient and 2 cranies, I think it was. Our spinal surgery's kicked up. Abdominopelvic pain has kicked up. Patients, we've used it in some really quite interesting patients with widespread pain. A patient needing extubation who had SJS and they needed to use something non-opioid. What else did we use? Guillain-Barré syndrome, a patient with Ehlers-Danlos that had respiratory depression and a respiratory arrest after being treated with opioids for fecal loading. It was quite strange. So some very interesting applications, and even I think in the last week we've managed to use it on somebody with chronic pain who's had to undergo a liver transplant. So situations where I would not have thought it would be possible to use an intravenous lidocaine infusion. And so from a nursing perspective, nursing-wise, there's a lot of groundwork that you have to cover when you're starting a process or a protocol like this in the hospital, making sure that you engage the pharmacy and the Drugs and Therapeutics Committee, the Nursing Practice Guideline Committee, making sure you get your education right, the after-hours services, and of course communicating to your anaesthesia colleagues and with your anaesthesia colleagues. Have confidence that the nurses can and do recognise early warning signs of LAST, empower them to stop the infusion. And the most important thing, I think, and the thing that I would like to practice and get better at, is teaching nurses how to do good patient assessment when they're asking for signs and symptoms of local anaesthetic toxicity, because when you give patients a list of things that you're looking for, they will find something on that list. So I would like to teach nurses to be better at just vaguely asking, is everything all right? Do you feel okay? So pre and post infusion assessment, also important. We've had to stop a couple of infusions for patient anxiety that was unfortunately present pre the infusion, so probably wasn't a result of the infusion. And the other thing that's I've noticed over the course of us delivering these infusions is how important the psychological, the social and the environmental factors are, as they are with all pain management, but particularly when you've got somebody in a heightened state and you're giving them a therapy that you actually think might work, getting that environment right, getting them in a calm, quiet room, using your calm voice and your calm demeanour, making sure that they feel safe is very, very important. Nurses on the wards need lots of support. It's been a while since I've been a nurse on a ward. One of our nurses is still a nurse on the ward, but they're very junior out there. They need lots of support. They need lots and lots of patience. So we do what we can to get the infusions started, making sure that we print off the protocol for them, even though we're supposed to be computer friendly now and environmentally friendly, we still print off the protocol, try to acquire the equipment, acquire the 20% intralipid, make sure that they know the important thing to get off the resus trolley is some DAS, empower, support. And if we say we're going to do twice daily reviews, then we nag and we make sure that the patient gets a twice daily review. And so my final slide is just lessons for anyone who would like to think about running intravenous lidocaine as either a rescue or a perioperative. We didn't run intravenous lidocaine on all perioperative patients. We did it on a lot of medical patients as well. Don't mess around with that starting in a monitored area business. Just do your protocol so that you're commencing the intravenous lidocaine on the ward. So far with our 31 patients, we've not had any problems. I would do way more education and teaching, particularly around the careful wording and the environmental factors. As anaesthetic doctors, I know you're all very patient naturally, but one of the things that we do find, poor old Dan, he orders a lidocaine infusion on a Friday morning and he gives the first bolus of lidocaine at 10 a.m. and he expects it to be running when he comes back at 2, and it's often not. So please have patience with the nursing staff. They're quite junior, they're quite flustered, they're quite overwhelmed. It's a busy time of year. So we do what we can, but have patience. Keep the safety rails on. And make sure that you consult with your colleagues as well about whether it's appropriate to give someone local anaesthetic, because I think, you know, we're all a bit conservative. And I think there's been times when we've thought, yeah, this person really could use some local anaesthetic intravenous infusion, and it hasn't happened, and it hasn't happened, and it hasn't happened. And then somebody comes along and orders it, and it's actually the game changers. So maybe talk between yourselves and ask each other whether it might be an idea to start one. And then, because I had limited time and I wasn't very well, I left the rest of the lessons to the acute pain nurses who didn't know that they would have to answer this question. Do you have anything to add? Any lessons that you think we've learned along the way, or anything that you would do differently? They're fabulous. They're fabulous. Thank you.
Thank you so much, Jill. That was an excellent talk. Before you sit down, I'm going to invite all the speakers back up over here onto the hot seat, and we can do a bit of a Q&A, which I'm sure there'll be many questions. Number one, first question is from Barry. Okay.
Very good question. So this year has been a tricky one, because prior to the change in what's available over this year, we were using the ambit pumps. I was sending everyone home with an ambit. We had a pump, disposable, rebatable, and it was all fine. And then all that changed, obviously, and then we lost that on the list. And then it became a bit more tricky. And so we're using CAD pumps. Now, I've got colleagues in Canberra who are going, stuff for you guys, CAD pumps they're on the list. So I'm sending my punters home with a CAD pump. They're $3,000 a pop. And you can put it in the bin if you like. Your medical fund will pay for it. That's uncomfortable for me. So we start to look at other options. At the moment, if they're having a cuff, I've put catheters in all of them. Some will say that's false. And we use the CAD pump and run it till the next day, and then really make decisions on that morning. On the whole, cuffs, they do go home the next morning, and among the CADs, I call it, decide what to do at that point. The elastomeric pump is the one that is on the list. So we've gone back decades now to the good old pain buster. I know Greg's got one. Yeah, he's got the one that's, for me, is the most usable. Is a 2 mil background that you can set a 3 mil bolus with a 30-minute lockout. The other ones are, 5 to 10 mil boluses with 30-minute lockouts, and the guy can put 22 mils into his neck every hour. That's yeah. So that's on the list as well. But the 2 mils an hour, 3 mil bolus with a 30-minute lockout, I think for me, that's the safest option. It's on the list now, only recently, but you have to. So Bethesda's now getting them. Hollywood, I think we haven't got them yet, which maybe we still got the other elastomeric. So I feel like we've gone a bit backwards with the elastomeric pumps. The question is do I still do it? Yes, I do, and mostly because I know what they look like the next day. Because, you know, for example, we saw two today, great primary blocks, and the reason we saw them, one was replacement, but the reason we saw them was because they had significant, and then the surgeon's gone. So, you know, pick those, I wouldn't pick them. So, yes, so cups, the short answer is I put more than, and then I decided what to do the next day. You're waiting to.
Is this working? No. Sorry, I didn't mention one of the other changes to the new guideline is you can run it subcutaneously. Yeah. Yeah. Not on the ward. No, not on the ward. But you just run it subcutaneously. Yeah.
Any other questions?
Look, it's possible. I mean, I guess in theory, your adductor canal block should be a purely sensory block and therefore shouldn't affect your mobility. I think the fact that you've got a local anaesthetic infusion bag tied to you might affect your mobility as well. But the mobility was, despite that, sorry, I see what you're saying, that whether the fact that they didn't have a catheter and then potentially didn't have motor block may have improved their ability to walk on the first day. That's because of the fact that it's a retrospective audit, it's difficult for me to say, entirely, but I guess we weren't able to discriminate between patients that weren't able to mobilise because of pain versus patients who weren't able to mobilise because of motor block. Certainly from having done APS at Hollywood for a while, we aren't getting messages from the physios that patients are struggling with motor block. And while it's a possibility, I think that since the introduction of the adductor canal catheters, for the most part, motor block is not the factor that's limiting them.
Brian.
I've got a question for Brad. The study of the catheters for the shoulder surgery was conducted over quite a protracted period of time, just my memory listening to the patients that you were talking about. And looking at the oral morphine equivalent daily doses, which works quite nicely if all of them were just taking tapentadol. The issue we have, I think, with using tapentadol is one of those analgesics is what number do we use? Looking at the data set that we put out in the Faculty of Pain Medicine for what tapentadol is for OMED, is it the oral morphine equivalent or is it the oral morphine analgesic equivalent? And there's a 5-fold difference in those two numbers. So over that period of time, were those two groups, were they just given tapentadol as their oral opioid, or was there a mixture of conventional and tapentadol?
They just got tapentadol, so that was our standard tapentadol.
Right.
The backup was hydromorphine was prescribed, PRN, but it was really just the tapentadol. The reason why it took so long was that when we started the study, we unfortunately had a tragic event with the surgeon's family. His dad passed away, so it was just carboshed really, the study for quite some time.
Yeah.
Then we had one as a COVID, and then we really got back into it, so it took a while. But yeah, on the whole, it was tapentadol.
Okay, so the OMEDs
That's
themselves,
what they were.
we were just comparing tapentadol equivalents.
Correct.
Yes.
Question for Dale. I think you showed some data, unsurprisingly, that blood sugars go up quite a lot with the 1 mg per kg. Are you excluding diabetics, or if not, what are you finding with the insulin and blood sugar control?
Yeah, that's a really good question. So at the moment, well, first thing I'll say is there's not a strict protocol of these patients will and these patients won't. It's only a couple of surgeons that are using this as part of their technique. But of those 2 surgeons, the current practice is to exclude diabetics. There is, from a review of the literature, even with the higher dose DEX, a suggestion that in non-insulin requiring diabetics, the DEX may still be safe from a hypoglycemia and infection point of view. But at the moment, I guess people are taking things pretty conservatively. I also think that one of the major take-homes for me is that we do still need a lot more safety data on the high dose DEX. So my feeling would be, at least until we have that, to be on the conservative side and exclude diabetics. Because of the fact that at the moment, these patients that are getting it are non-diabetics, it's not part of their usual post-op pathways to have blood sugars taken. So we kind of don't really know what's going on there. But yeah, to answer your question specifically, non-diabetics at the moment.
Mitch.
Again, our ortho Jerrys are pretty against dexamethasone overall. I think if you mentioned to them we were going to give them 1 milligram per kilogram, they'd go bananas. From what you've seen, have people been only giving it to the younger patients, or it hasn't been a problem no matter the age?
So it hasn't been restricted to just the younger patients. So I had a 92-year-old guy tell me he felt like he was 27 again on the first day after his knee replacement. So yes, maybe that's the steroid talking. So it hasn't been restricted. But what we certainly have not seen at all is delirium, if that's certainly a concern. I mean, in terms of the pathophysiology of delirium, it's thought to be an inflammatory process, and it may well be that dexamethasone is in fact protective for delirium. So I speak purely from my experience and what I've observed rather than what I would advocate. But yeah, so far age has not been a limiting factor.
Just wondering for Brad, in the sham group, what did you use for local and did you use adjuncts? And was that standardised? I think I missed it.
No, so it was just 15 mils of 0.2%, so no adjuncts for the sham group. And then in recovery they got the sham bag, saline, or the ropey. So no, I didn't use any adjuncts.
And is that because nobody's using dexamethasone in single shot blocks where you work? Or?
I just purely for the study we just standardised. I think if you are doing then I think from a rebound pain point of view, I think dexamethasone's. So if I was going to do a single shot block, I'd put 4 milligrams of dex in it definitely.
Did they get 5 EDEX?
All at 8 milligrams of RB-dex, yeah. So, yeah, the systemic versus base sites. But I think there's a fair amount of evidence now, Brian will correct me on this, about the perineural dex having more of a benefit from a rebound pain point of view than the systemic dex. So, although from a block duration point of view, there's mixed in the literature, but from a rebound pain point of view, it seems like perineural dex is if you're going to do something, that's the way to go. Is that the way you understand, Brian?
Yeah, it's like, I explained, it's like vaccination causing autism. And there's one study in the planet that showed that giving systemic dexamethasone improved the block outcome. there's like 3,000 to show that it's perineural that does it, but everyone knows about the vaccination causes autism.
Dale, you're pretty far away from getting a knee replacement, I assume. Would you be happy to be enrolled in this trial and be subjected to 80 milligrams of Dex if you needed knee replacement tomorrow?
He has it every Friday morning.
It's part of my diet now, yeah. Look, based on my review of the literature and failure to demonstrate any harm and encouraging, so far first-hand experiences, I probably would say, yeah, I'll go for it. Yep, give it a crack. Yeah, no, I would. I'm encouraged by what I see. Again, I find myself trying to be as objective about this as possible and not, getting caught up in the energy that the surgeons have, because there may well be a strong placebo effect here because of how much enthusiasm there is, or whatever they've seen from this centre in France. So I don't want to be swept up in that, but in terms of allowing myself to be randomised, yeah, sure.
Any other last questions? Yes, Erica.
So, Dale, I wanted to know, I guess at the moment we've got but do you think potentially there could be
Yeah, absolutely. So I personally don't feel like we should ditch the ACCs. We're definitely seeing some patients who are amazing with the DEX, but how do we predict which ones aren't going to be? And I think the data's been presented at this meeting previously on the benefits of an ACC, certainly from doing APS and having the ability to bolus or to tinker, as Brad says, is incredibly beneficial. And I do worry in this randomised control trial that in that 8 milligram group, they're not going to have an ACC and they're not going to have high-dose DEX. Are they going to struggle? So I definitely think we shouldn't just throw out the ACC. I think for the moment, and until we have a better ability to predict the patients that are going to struggle, there's still benefit in having that.
And the question for Brad was just, it's interesting that the surgeon noted that having the catheter in makes such big difference at the 6 or 8 week review with patients. So do you think excluding that group of high-risk patients in your trial, that's the group that benefited the most from that intervention? Or was there another reason?
I think so. I mean, when you look at the literature with continuous techniques, it's always a group that they exclude. And for the trainees that come through and I try and teach them, I'm like, well, when you're going to need it to really work is one, if you've got a consultant anaesthetist, is the morning one, and the other one is when you've got these kind of punters, chronic pain, opioid tolerance, on buckets already, had previous CRPS, and now they come in and they've got a rubbish supraspinatus. Then that's the one that really warrants 3 days at least of a catheter. Those are the ones where I don't do catheters. And start the methadone, the gabapentin, entirely. So it would be great if we had what those patients look like with catheters at 6 and 12 weeks and what their functional outcomes were, definitely. And I think the same with the ACCs. Obviously, a proponent of continuous catheters, so everybody goes more for it. They're fine with single drug. But the reality is, the punters with the ACCs, my N of 3 consultant anaesthetists having knee replacements, they all had catheters, demanded catheters. One of them, it was stopped at day 2, and she almost bit the surgeon's head off and demanded it went to day 3.
And they also had sort of multimodal stuff as well on top of that. So either we're a little group as wusses, or the reality is they know the benefits of the catheters and they all had one. So I think I'm with Dale as far as the surgeons rah. I had to say, you know, when they first come back from France, just give them a bucket of steroid, you can stop all this bullshit. Stop the spinal and the catheters, and I'll put the local in, we'll give them the steroid, put them to sleep, wake them up, and be fine. I can tell you those punters in recovery were a shit show. There's a reason we put spinals in, there's a reason we do nerve blocks. And I think the one that Mark's done, if it was me, I want the steroid and I want the ACC, don't go with the ACC. But it's a bit tricky when you're doing big RCT, and I think you need to think about how you do that. So I think probably for the RCT, we just do the simple.
All right, I think we'll call it there, guys. Thank you very much for coming. Thank you to the speakers.